Good morning. In obsessing about this presentation this morning, I decided to say something as a preamble. And my preamble is that, as far as I can see, there are 6 charming and often exasperating characteristics of adolescence. They are their tendency to be certain, their emotional intensity or passionate responses, their intrinsic reaction to their status as in their peer relationships. They're porous in terms of absorbing their current culture, in terms of politics, the internet, and clothing. They're seeking trustworthy authority figures, teachers, clergy, therapists, politicians, all the while evidencing cynical distrust of those authorities. And finally, and most importantly, they're changeable. Next. The sources for understanding are the antecedents of a new gender identity are published literature, the patient's previous evaluation reports from other professionals, the conversations with the previous therapist or pediatrician, our past clinical experiences, and most importantly, our role as an evaluator or therapist with the patient. And that brings us into contact with the parents, the adolescent themselves, an older sibling sometimes, and hopefully sometimes our own supervisor helps us understand what we're seeing. So where do the antecedents of gender identity work? The answer to me is very clear. Within the unseen mind of the patient, historically we call that the psyche. When do the antecedents operate? Well, they operate remotely in the past, in the early life. These are what we call the precipitating factors. That involves temperament of the child, the biologic disadvantages of the child, both congenital and acquired, their attachment adversities, if they exist, psychosocial developmental events in the family, things like divorce, frequent arguments, sickness or death in grandparents or parent, right? Personal disappointments with oneself. I think I should repeat that. Personal disappointments with oneself. And victimization, various victimization experiences that all of us would agree would be physical, sexual, or neglect. But there are precipitating factors to a new identity as well, and they are the factors that happen within months of the synthesis of myself as a different person. These have to do with peer problems, new intense relationship, often romantic aspiration, internet experience, which we've talked about endlessly here and correctly, pornography exposure, which I think we might not appreciate how horrifying that can be to children, distress over one's perception of its sexual attractions to the same sex, powerful interfamilial events, for example, watching physical violence between members of the family, and larger cultural influences which are very, very difficult to grasp in its entirety. So when do antecedents occur? They occur both remotely and more recently, and they each category consists of numerous factors. The antecedents bear a largely unrecognized relationship to 4 things. the patient's subjective experience of gender dysphoria and its attendant behaviors, the patient's immediate mental health and social consequences of acquiring a new identity, the stability of that identity, and the impact on the parents and the siblings of that new identity. So what I mean by this, I think, hard to understand concept is our field has not matured enough to recognize how different antecedents impact these four dimensions. The diagnosis of gender dysphoria focuses on the sameness of patients, but when you sit with your second patient, you realize that your patients are different from one another. So why is the identification of antecedents important? Well, for a number of reasons. First, to answer the question, what mental processes have led to this new identity? That seems rather obvious. To identify the target of effective clinical interventions, that is more subtle but vitally important. To provide guidance to the parents who usually need it. To make suggestions for the patient and to the family for changes that can be brought about. And to tell the truth to the patient. To tell the truth as we understand it to the parents. And to tell the truth to ourselves. And eventually, if we're not going to be the therapist, to tell the truth to the next therapist. So when the evaluator asks the patient two questions, which I believe we should ask all these young people, what is your understanding of why you have abandoned your previous gender identity? Really, explain to me. Why have you abandoned? How do you understand the reasons, the motives for abandoning your identity? And the second question, what attributes of the other gender do you desire to possess for yourself? I ask these questions to everyone. I tell you that the vast majority of the people who hear these questions posed to them, even older adolescents, initially say to the first question, I don't know. And to the second question, the answers are vague. Now, I want to say about that, wow. Wow. You mean to say, and you can't explain? And that's what I see over and over again. So it's our responsibility, ladies and gentlemen, therapists of all kind, it's our responsibility to help the young person over time begin to cogently answer these questions. Why is it that you have repudiated your gender? What is it about the other gender or sex? What attributes do they possess in your mind that you would like to incorporate into yourself? I remember early on someone said, well, girls have emotion and they can cry. Wow, again. I remember crying as a little boy all the time. Our field has thought about the antecedents for 25 years, really, with increasing clarity about the answers. However cogent, these remain hypotheses to be tested by the patient as they understand themselves better. They are only hypotheses. We may think they're causes or influences, but they're hypotheses. And hypotheses need to be tested. And in a clinical setting, the test of hypothesis is what the patient feels and thinks and responds to, you see. And we get a joint conviction that that hypothesis was right or wrong, or it was only a part of the situation. We reject, or at least I reject, biological determinism without denying for a moment the indirect susceptibility of biologic contributions through temperament, through neuroatypicality, and specific learning and skill deficits, and this might surprise you, through elite intellect or athletic capacities. Some kids are very, very, very smart, and they're smarter than everyone else, or they're better in some athletic endeavor and anything else. The star of a men's Little League team in my first patient was a girl. So mechanisms of trans identity development are not fully conscious to the adolescent. It's one of the reasons why they can't answer the question, why are you repudiating this? So my conclusion is there is no common single pathogenesis of gender dysphoria. Abandon the idea. Multiple factors converge to generate a new identity. The predisposing and precipitating factors differ from one patient to another. So I just want to give you some examples. Autism, genius, and social failure. Early sexual victimization, academic failure, substance abuse. Incest, parental alcoholism, and recent maternal suicide attempt. Athletic superiority, homophobia, paternal hatred, familial intense religiosity, shyness, and tomboyism. Well, these are just triads of cases that you've seen, right? And at any given time, you may be focused on one aspect of that triad or maybe 6 factors. I don't know what the word for 6 things are. But in psychotherapy, given at any moment, different factors seem most relevant. Never believe one factor is the major one, even when detransition has occurred, when patients realize, though, is my fear of being homosexual, or I was not thinking clear enough because I was too young. I just wasn't thinking about the consequences. Or, listen, I was only 13 years old, right? There are multiple factors combining, converging to produce even that one insight that enables people to have the courage to detransition. So as has been stated twice in this Congress, I have this overarching hypothesis. I don't pretend like it's true. I call it a hypothesis. It's to be tested. But I do think in general, a new gender identity is a creative act. It's an unconscious creative act. It's a it will prove to be, for most people, a maladaptive solution to a previous state of despair, disappointment with oneself, or disappointment with one's family processes or one's parents. Now, to that hypothesis, I think we should add the frequent presence of psychiatric comorbidities. There are 3 possibilities to explain the relationship of those comorbidities to the new gender identity. One is the new identity represents a hope for escape from depression, anxiety, symptoms of eating disorder, self-harm, recurrent suicidal ideation, the inability to pay attention, OCD mechanisms. In other words, this is an attempt to reinvent the self, to have a rebirth. I want to become a new person. I don't actually think I could be a successful man and woman given my current personality with all of its burdens. The second way of thinking about this is that comorbidities reflect the frustration of unrecognized sex-gender incongruence. And when they're perceived, there's an unacknowledged ambivalence that maybe this is not the good idea. maybe this is not a good idea. Remember those characteristics of adolescents? They present with certainty and passion. But beyond that, they have ambivalence. They have hidden conflicts, worries about, is this a good thing? Is this the right idea? You see? And I think one of the blind spots in affirmative care is that they don't see the ambivalence. They don't want to recognize the ambivalence. And I think it's all over the presentations. And the third way of thinking about the relationship between the comorbidities and gender dysphoria is that, oh, they're not related at all. It's like diabetes and a fractured elbow. They're not related, you see? And I've heard that argument from people. Obviously, I like the combination of one and two. The implications of comorbidities as vital antecedents for planned psychotherapy. This is what really I do for a living. I evaluate people in order to try to help them in a psychotherapeutic process. So there are also two major ways of thinking about this. One is that therapy focuses on the predisposing and precipitating factors for to treat the comorbidities. Not the gender dysphoria, the comorbidities. We don't discuss in this approach the new identity until the patient brings up their gender themselves. And this is based on the idea that gender dysphoria is an epiphenomenon. It's something that comes from something else. It's the surface manifestation. And so what we're trying to do is relate to the symptoms that the patient has and can conceive, because they bear it, and we help them to work that out, to find meaning in those symptoms, and to overcome, to outgrow through maturation and understanding what those symptoms are, and under the hope that that will change their ability to think about themselves as needing a rebirth. They need more self-acceptance than a renaissance to become a new person. So this facilitates the therapeutic alliance, which is vital, of course, and it allows everyone to understand that the patient's future happiness, by everyone I mean the patient and their parents, and the therapists, their future happiness and their future functional capacities are at stake here. Because this 15-year-old is supposed to live for the next 65 years. Our therapy is an investment in the rest of this person's life. So that's point A, the implications, the first set of implications. The second set of implications is that when therapy focuses on the antecedents and the motivations of the new gender identity itself. Now, this is not a bad idea. But this requires a greater degree of skill on the therapist and honesty about the therapist's own sensibilities about this whole idea. It requires the therapist to have an impressive capacity to maintain a consistent respect for the patient's current and future gender choices. I do actually believe that the patient's responsible to construct a gender identity for themselves. It's not my business to tell them how they should live, right? Even though I privately feel life would be a little better if they could return to their original identification. So the concept of individual therapy for gender dysphoria is relatively new, right? Obviously, we don't have any placebo-controlled trials. We don't have systematic follow-up of accounts of those who have had individual therapy as their first treatment. We don't know the outcome of that. We believe that this is what we should do, but we don't know that on any scientific way, right? Psychotherapy is based on the knowledge of the sources of suffering. It is also based on the tradition of treating psychiatric problems. It requires faith in the process, right? And it rests on our intuitive sense of how to help people. through relationships, through high-quality, respectful relationships. Mental health professionals need support through supervision and opportunities to share processes with others in settings like this. Since we don't have science, we have our network. We have our ability to talk with one another, to give each other suggestions, to formulate hypotheses that might be useful when you take it home to your clinic. See? Administering a medication, which often is indicated in my psychiatric view for many of these patients, is an adjunct to psychotherapy. It is not a substitute for psychotherapy. Psychotherapy has growth-promoting potential. We help people to mature by understanding their internal world and the external world. So the family, remember, is the crucible in which a child develops from helplessness to autonomous self-regulation over a process of about 20 years, called family. The amnesia for the first 5 or so years that all of us have means that no young patient can tell the evaluator about their early processes that shaped their lives. Therefore, we must involve the parents in the evaluation and the ongoing processes. Parents' accounts are limited by their memories, their understanding of themselves, and their understanding of their child, and their willingness to tell us about embarrassing past processes in the family. The nice thing about dealing with parents is that they tell you more over time. They didn't trust you enough to tell you when they first met you, right? Initially, we asked them to describe, at the very minimum, we asked them to describe the mother-child relationship and the father-child relationship in detail. We're asking the parents to talk about their view of how the child and how they relate to one another. That opens up the door, you see. A diagnosis of gender dysphoria is not a reason to be disinterested in the developmental processes, unless one thinks, as we do not think here, that the diagnosis should lead to hormones without delay. Most families that I've ever met do not want a quick access to medicalization. Parents need guidance. We agree to see the parents regularly, but usually not less frequently than we want to see their adolescents. We're trying to maintain good boundaries while doing this. I prefer this than to send the parents to someone else for parent guidance, because I did the evaluation. They bonded to me. They're trusting me. And they know I understand how they understand their child. And to start over with another therapist seems like a rejection to them. A new gender identity can emerge in families that continue to be perceived by the evaluator as healthy families, as normal, positive, and loving parents without major trauma. And when that happens, either whatever adversities happened in the past, the family has already helped the child to master it, or the child is caught up with environmental issues that are shaping their sensibilities. See? So we look very closely in those situations, to pubertal experiences, the changes of puberty, the social milieu in which the child lives outside the home, often in the bedroom with a computer, right? And their aspirations to be part of the world-changing event. The world is changing concepts about how to be a man and how to be a woman. And they want to be, because they're young people, they want to be on the front of this process. They want to join the revolution that is happening, the social, cultural, intellectual revolution. We admire those intelligent people. We remember that we wanted to be part of that too, you see. So parents tend to think they caused this in some way. they often cryingly ask me, how did they damage their child this way, right? Parents, typically mothers, often are psychiatrically deteriorated upon the announcement of this. Mothers suffer seemingly much greater. I think I've administered antidepressants and psychotherapy to mothers very frequently. Fathers suffer too, but they internalize it much more. As I think they drink more. So a parent of a grade school child who's trans-identified, I like to think that we should focus only on the child's psychiatric issues, right? We should regularly follow them up, like every 3 months, and to see what is emerging. Parent guidance without the child, I think, is a very reasonable approach. We want to encourage good reality testing about what is possible in life. We want to frequently discuss peer relationships, the child's peer relationships with the parents. We encourage parents to help their child into extracurricular activities to build new skills and confidence, right? And we ask the question, what can this particular child excel in? Because I think excellence, competence, strengthens masculinity in boys and femininity in girls, whatever those terms mean. The love of the self, the belief in the self, right? Lots of questions arise in every family with a trans-identified child, and I think parents need to handle these various moments well, and who else are they going to look to think about how to handle this but you, right? So I think these same suggestions should apply whether the child has been transitioned or not. Parents need help. So that's the end of my remarks, and I wanted to save some time for questions. I thought maybe the Q&A would be even more illuminating than my prepared remarks.